afternoon. Thanks for coming. Most of you guys know me. My name's Alex. I'm a second-year resident here in the IM program. And today I'm going to be talking about the myth of contraction alkalosis. For most of my medical training and time in residency, I really had no idea that this actually might be a myth. But just a few weeks ago, it was brought to my attention that it might be. And I did some digging and found some pretty interesting things. So excited to share those with you guys all today. Disclaimer, this is going to get kind of complicated. So with that in mind, going to start things off a little light with just a little collage I made of general things that I love. Here in the top left, we have a beautiful Santa Barbara sunset in Isla Vista. That's actually my house. I used to live here. On the right in college, we paid like $500 a month to have that view every day. Here on the right, we have my two beautiful nieces, Olivia and Nicolette. This is Olivia over here on the right. She's 9. And then Nicolette's the little one. She's 4 now. We see Nicolette had the ingenious idea of putting raspberries on her fingers like little hats. Really cute stuff. Here on the bottom left, we've got a protein burrito from Super Kukas. It's got beef, eggs, rice, beans, guac, and cheese. And then here we have the Golden State Warriors celebrating their 2022 championship. Their 4th championship in my lifetime, which is really nice considering they're really bad for my whole childhood. So, okay. Next, I'm going to hit you guys with a quote from my boy Confucius. Actually, I'll give Dr. Freed some credit as well because I actually got it from one of his talks originally. So the quote is, "The beginning of wisdom is to call things by their proper name," which I thought was particularly relevant to this talk. Okay. So getting into the nitty-gritty, I want to start off by kind of talking about how the idea of contraction alkalosis originally came to be. So it turns out that the first time this term was coined was in 1965 by a group of researchers led by Dr. Cannon, who had basically studied the effects of ethylcrinic acid, which is one of the oldest loop diuretics, then new at the time, on the electrolyte profiles and volume status of 4 CHF patients that they had used to diurese with it. And so basically they were measuring their urine lights and overall volume status, and they found that in their studies, it was pretty consistent with what we now understand is just the common effect of loop diuretics. So they had profound urine losses of sodium, chloride, potassium, and water. And with that, they had significant decreases in their extracellular volume. Along with that, they also saw significant increases in their bicarb concentration, and along with that, their pH. So they had a metabolic alkalosis. And they also saw compensatory increase in the PCO2, so a little compensatory respiratory acidosis. What was interesting is that they saw this increase in bicarb despite a mild or inconsistent loss of either acid or base. So they weren't really losing a significant amount of protons in the urine to account for this increase in bicarb. And another interesting finding was that the metabolic alkalosis persisted for several days after they stopped diuretics. So they were trying to figure out why this could potentially happen. Why were they seeing an increased bicarb concentration and increased pH when they weren't losing acid in the urine? And so they looked at a couple things, including whether the bicarb was shifting in and out of cells and whether other buffers that were in the extracellular space were playing a role. And they did a bunch of complex math that I didn't really understand and calculated that neither of these factors were really significant. So based off that, they pretty much determined that since there wasn't any net loss of acid that was significant, no net intracellular or extracellular movement of bicarb, and no other buffer was significantly playing a role, they assumed that this increase in bicarb and this metabolic alkalosis must be due to a contraction of extracellular fluid around a stable amount of bicarb. Here's just a little illustration of some of the measurements they had. So as you see, all the patients lost a significant amount of electrolytes, but here in the middle we see that they didn't really lose a significant amount of protons, and sometimes they even actually gained. So this didn't really account for all the increase in bicarb that they saw. And here we saw that all the subjects had a decrease in their ECF that was pretty proportional to the amount of weight they lost. So most of the fluid they were losing was extracellular fluid. Here's another little illustration of kind of their schematic of what was happening. So you start off with a bunch of volume, a bunch of sodium, potassium, and chloride, and a stable amount of bicarb. And with diuresis, you have less potassium, less sodium, less chloride, but the amount of bicarb is unchanged. So the increase, overall, it's a net increase in bicarb concentration. That's kind of like a visual look at it. Looking at what they were kind of thinking in the mathematical sense, it's interesting because, if in vitro, outside of a human body, if you have a solution and you're decreasing that volume, that shouldn't affect the pH up or down. You are going to have an increase in the bicarb concentration by decreasing the volume, but the pH is dependent on a ratio of the bicarb and the PCO2. So in theory, you should have an equal increase in your PCO2 if you're taking away that volume. And that's what would happen in vitro, so you wouldn't see a change in the pH. But in the human body, what happens is actually as the PCO2 goes up, our lungs are immediately able to breathe that off. So that basically takes out that factor, and we're compensating for that in real time. So what we see is an increase in bicarb without an increase in PCO2, and that's going to lead to an increase in pH and a metabolic alkalosis. So this is kind of their theory of what was happening. The question, though, is why was this alkalosis maintained? Why didn't the kidneys just secrete all the excess bicarb fairly quickly? As I mentioned, the alkalosis persisted for several days after they stopped the diuretic. So the original authors of that paper proposed a bunch of different theories of why this diuresis and all the losses that they had kind of stopped the excretion of bicarb and compensation by the kidneys. These theories range from sodium deficits to potassium deficits to decreased volume, leading to increased activity of aldosterone or decreased GFR, all of which, for some reason or another, stop the kidney from excreting bicarb. There was another study just a few years later by a group led by Dr. Cohen in 1968, and they were basically just trying to parse out which of these factors could be playing a role in the maintenance of the alkalosis. So what they did was they diuresed some dogs with ethacrynic acid, and they induced a metabolic alkalosis, and they maintained that for 5 days. So they used ethacrynic acid, and then they had this alkalosis. And then what they did was they corrected the alkalosis by infusing the dogs with chloride-rich solution that mimicked the dog's blood concentration of other electrolytes. So they weren't giving them more acid or base, they weren't giving them more sodium or potassium, they were basically just giving them volume and chloride. And they found that with that, the kidneys were able to correct the alkalosis. And they knew it was the kidneys because they could measure what was coming out in the urine. So it seems like it's not a deficit in sodium or potassium or anything else, but really it's either volume or chloride that they're giving that's fixing the metabolic alkalosis. And they assumed that it was the volume, and that kind of further perpetuated the idea that it's contraction alkalosis. Their theory for why this is happening is basically illustrated here. So what they thought happened was when you have decreased ECF volume, you have decrease of blood flow to the kidney and decreased GFR. When you have decrease of GFR, the kidney is going to compensate for that by reabsorbing sodium in the proximal tubule. When sodium is reabsorbed in the proximal tubule, you're going to have obligatory anion reabsorption, and the proximal tubule absorbs bicarb more than it absorbs chloride. So it's this reabsorption of bicarb that's leading to the alkalosis and stopping the kidneys from fixing what's caused by contraction. And then basically what they thought was once they repleted these dogs with a high chloride solution, they were fixing their volume problems, so they were increasing their GFR, which made it so they didn't need to reabsorb all this, and thus they could have excretion of bicarb in the urine and some reabsorption of chloride, and thus the alkalosis would be fixed. So that was their theory. Around the same time, a study in 1968 actually found that chloride was a necessary component for the fixing of the alkalosis. This study also used dogs, and they created a chloride depletion alkalosis, or a CDA, in several ways using gastric aspiration, diuretics, sodium nitrate infusion, and previous hypercapnia. And then they had two arms, one of which they repleted with a sodium chloride and potassium chloride solution, and one that they repleted with volume and sodium and potassium, but without giving them any chloride. And they did this with giving them like sodium phosphate, potassium phosphate, other things that just didn't have chloride in them. And what they found was only the groups that were repleted with chloride actually had a resolution of their metabolic alkalosis. When they gave people volume and sodium and potassium, that did not correct the chloride deficient alkalosis. And so this was kind of the first study that cast some doubt on whether it was really contraction that was the reason that the alkalosis was being perpetuated, showing that chloride was also necessary. It wasn't until another 20 years that further studies were done by a group led by Professor Gala that looked at whether it was actually the chloride or the volume expansion that was correcting the alkalosis. So the first study they did in the second box here, they basically used peritoneal dialysis and created a chloride-depleted alkalosis in rats. And they did this without altering any sodium or potassium balances or concentrations, so that was kind of taken out of the equation. And they then had two arms. They either replaced them with sodium chloride or choline chloride salts. And they kept dialyzing them while they did this. So they had net negative balances of potassium and water. And in the group that didn't get any sodium, they had a net sodium negative balance also. And they found that in both of these groups, whether they were getting extra sodium or not, the metabolic alkalosis was quickly corrected by the kidneys in less than 24 hours once they got the chloride, even though they were continuing to lose water and continuing to lose potassium. So that really kind of points to volume not being the issue of why the alkalosis is persistent. They had another study here in this next box where they infused chloride-deficient alcoholic rats. They created it the same way with peritoneal dialysis with either 6% albumin or a symmetric chloride solution. What they found was in the albumin group, they were able to expand their ECF volume by 15%. And despite that, these people had a decrease in their bicarb excretion and a persistence of their alkalosis. So volume expansion without chloride repletion did not fix the alkalosis, whereas chloride repletion without volume expansion, where they actually further dialyzed off volume, did correct the alkalosis. So that was particularly notable because in these patients, in the chloride group, they actually were measuring GFR and found that the ECF volume and the GFR were still decreasing. So that kind of poked a hole in the previous theory that it was dependent on GFR and proximal tubule sodium reabsorption, because even in the face of decreased GFR, the alkalosis was still corrected just by increasing their serum chloride concentrations. Lastly, they did one last study where they basically looked at the same thing, but in humans that were given a chloride-depleted alkalosis with Lasix. And what they found was that after they maintained this alkalosis for 5 days, they had two arms. One got potassium chloride with overall further contraction using dialysis, or sodium phosphate. They found that the sodium phosphate group saw further increasing bicarb concentration despite volume expansion, and they found that the potassium chloride group saw a rapid correction of the alkalosis. So basically, again showing that, now this time in humans, not in rats, that volume expansion without chloride repletion does not fix the alkalosis, but chloride repletion, even in the face of further volume depletion, fixes the alkalosis, calling into question whether contraction is the real mechanism of why this alkalosis is happening. And so, unbeknownst at the time of the 1960s when they first put forward this theory, there is actually a well-studied transporter in the collecting duct that kind of explains why this happens. So this transporter is called pendrin, and basically it's an anion exchanger in the tubular lumen of the collecting duct. And what it does is when there's a high chloride load, it reabsorbs the chloride and it secretes bicarb for the chloride. And it actually gets upregulated in the presence of high chloride delivery to into the collecting duct, and gets downregulated if there's low chloride delivery, and that happens pretty quickly. So basically this explains why when we gave people chloride, they were able to secrete their bicarb and correct their alkalosis. And here on the right, we have kind of illustration of the transporter. So this is the tubular fluid here. And so as high chloride containing urine comes here, this chloride's shoveled in and bicarb is excreted out. So this shows why getting rid of the excess bicarb is dependent on chloride. So in summary, the common understanding of what we call contraction alkalosis comes from one study in 1965 that found that bicarb increases in the absence of bicarb losses or hydrogen losses during ethylchronic acid diuresis. And interestingly, this study is kind of the one study I found that was actually pointing towards contraction alkalosis being a thing. If you look on UpToDate or NCBI or other review articles, they basically just cite this one study. Since then, there have been a bunch of other studies that have shown that alkalosis is corrected by the kidneys when chloride is repleted, even in the face of further volume contraction. And I forgot to mention this, but also in high aldosterone states, since one theory was that decreased aldosterone is actually, or increased aldosterone is one of the causes of the alkalosis. They actually showed that even if they give people exogenous mineralocorticoids to keep aldosterone activity high, they still correct their alkalosis when they're given chloride. But if you don't give people chloride and you replete them with volume, sodium, potassium, that does not correct the alkalosis. And there's a likely mechanism by which this happens, the well-studied transporter pendrin, that works in the collecting duct and basically excretes bicarb when it sees chloride being delivered to the collecting duct. So bottom line, based off all this, contraction alkalosis is not a good name because it's not the volume contraction that is causing the alkalosis or the persistence of the alkalosis. It's really the deficit in chloride. And when you replete the chloride, even if you don't replete the volume, the alkalosis corrects. So just a quick slide on like how this affects clinical practice. Looking into it, it really doesn't change what we do too much because coincidentally, pretty much everything we do to replete chloride also involves giving people volume for the most part. So we're doing the right thing, but for the wrong reasons in these patients, and it's still fixing their alkalosis. One thing that I found interesting and to keep in mind if you have someone with a chloride depleted alkalosis is different fluids have different concentrations of chloride. So normal saline has 154 milliequivalents per liter, whereas isolite only has 98. So if you are giving people's fluids for the purpose of correcting contraction alkalosis, I think it makes more sense to give them saline than isolite. I was also kind of curious with, in one of the experiment arms, they gave people albumin and that actually worsened the alkalosis because they were getting more volume, but they weren't getting any chloride. So their chloride concentration was actually going down in their serum. So I wondered whether when we give albumin for this purpose of volume repletion, does that not correct the alkalosis? But when I looked into it, modern day albumin preparations actually are in sodium chloride, so we're still giving people chloride when we give them albumin. So if you wanted to give someone albumin for any reason, this isn't a reason not to do that. A word on Diamox is another thing we commonly use, a diuretic that we can use in contraction alkalosis that continues to diurese people if we want to get further volume off, but actually corrects their bicarb. Interestingly, it actually works by increasing proximal tubule bicarb secretion and increasing chloride reabsorption there also. So not only are you getting rid of bicarb that way, but you're also increasing the serum chloride. So it's a good way to correct the alkalosis because even after you stop giving them Diamox, they'll have increased chloride and that'll help fix the alkalosis. And then a word on potassium repletion. In those studies, they found that potassium repletion on its own does not correct the alkalosis, and that chloride was necessary. But I would still say potassium repletion is very important for the prevention and correction of metabolic alkaloses because we know that potassium contributes and worsens alkaloses by increasing the amount of protons being shoveled into cells, and it also inhibits the kidney from getting rid of bicarb. So definitely, if you're trying to prevent an alkalosis, giving them potassium is definitely prudent. And I mean, it makes sense because in the study where they were correcting the alkalosis of humans diuresed with Lasix, they were giving potassium chloride. So they didn't look at what would happen if you didn't do that. And then one other thing, I don't have a bullet point for this, but one other interesting point I was kind of thinking of is if it's really chloride depletion alkalosis and not contraction alkalosis, it kind of draws into the question, I think, our practice of often when we're diuresing people, we're looking at their bicarb as one of the indicators that we're diuresing them too much and they're becoming volume depleted. It looks like based off this that whether they're volume depleted or not doesn't have as much of a role in whether the bicarb's going up. So maybe it'd be good to have a study specifically looking at how much the serum bicarb actually correlates with volume depletion, in extracellular volume depletion in patients being diuresed to see if that's a good marker or not. Yeah, that's all. Any questions?
Just metabolic alkalosis, one of the illness schematas we're sometimes given is chloride resistance versus chloride responsive metabolic alkalosis. So somebody's already kind of thinking on these lines, at least in terms of, maybe focusing more on the chloride as you've pointed out here. Excellent presentation.
Thank you. Yeah, and to my understanding, like the chloride responsive alkaloses, like all the diuretic-induced ones fall in that category. And it's more like net loss of bicarb that would be chloride resistant, I think, though don't quote me on that. But yeah, I think nephrologists, it seems for the most part already kind of see it in this way. And I think it's just a good idea to call it by what it actually is, as Confucius would advise us to. Dr. Joseph.
So that was fantastic. I love that. So clinically, frequently what happens is people will develop a metabolic alkalosis of whatever, and then, or someone is given a loop diuretic, and they appear to be, their creatinine may be going up, they may have AKI, so you send off urine electrolytes. The interesting thing is that if someone has a significant metabolic alkalosis, they're going to be dumping bicarb in the urine, and the bicarb will drag sodium with it. So when you look at your fractional excretion of sodium or urine sodium, you may get a higher number than you would if they were not alkalotic. And under those circumstances, you say, well, what's the urine chloride or the fractional excretion of chloride? And that's where you have that distinction that Dr. Bordowski kind of alluded to, where you have a low urine chloride, which would be the chloride responsive metabolic alkalosis, or the high urine chloride. And the distinction for that is that frequently, if you have metabolic alkalosis and you're not volume depleted or having low urine chloride, that's when you think about mineralocorticoid excess syndromes. That was awesome, Alex.
Thank you. Cool.
Oh, yeah. All right, that's great. That's a great presentation. So we're gonna, as usual, vote. This is how we phrased it. Is it a myth? ACF volume contraction is the primary cause of the metabolic alkalosis, commonly known as contraction alkalosis. So I just editorially, I was taught about this. I've still up until recently, well, probably till now, talking about contraction alkalosis. We did use the urine chloride for chloride responsive versus not, but we still called it contraction alkalosis, and clearly that's not what it is. And then, this goes back to 65, and it took 20 years for the studies to actually show it wasn't, and now 30 years later, including the time that I trained, still learning about contraction alkalosis. So this is a long-standing myth. Okay, in my opinion. Okay, that's my editorial comment. Okay, so how many people think this statement is true, that we should just continue to call it contraction alkalosis because that's what it is? How many think it's plausible? How many think that this is busted? Yes, unanimous. Good job. Okay. All right, we're busted.